experts in the world of normal birth from the beginning of history until I believe history closes its pages are midwives.
I realized that the only health workforce that can give a respectful maternity care for women is a midwife.
Every mother has the right to have a safe normal delivery and have a safe childbirth, for which she needs a midwife.
I think the most important thing that a woman and a newborn need in regards to maternity care is a competent, kind midwife who becomes her friend and her professional advisor, who keeps fear out of the room, who encourages her.
I think the first and most fundamental thing that they want is a confidence in the care provider that they have. The confidence that this care provider can do for me what is necessary or can pass me on and be with me if something else comes.
The word, the midwife itself means the with women.
I don't know if we need a definition of a midwife, but whoever is doing the work of being with women, which is what midwife means, and helping them through pregnancy and through birth.
It's not only the mothers, it's for the nation, because mother is going to bear the baby who will become the future citizen of India. It is all the nation to recognize the role of midwife in each one's life.
I think women and baby and also their families are in a very sensitive situation, and they need someone else actually to take care of them. In this situation, a woman cannot do it on her own. She needs someone who gives her that room and space and time, and guidance through this process, and also to help her maybe to make decisions important for them in that moment.
So we want mothers and babies not just to survive but to thrive. So I think it's very important that care providers really look toward normal physiological birth as a bigger picture, as a future picture of health for generations to come. And that is what mothers and babies are wired for. They are wired to meet one another at birth.
We know that if you leave anybody, an obstetrician, a midwife, a nurse or a dye, in a place where there's no water, electricity, equipment, nobody can save a woman who needs a cesarean section. It doesn't matter who you are. But we also know that the companion at birth speeds up labour, reduces pain and improves outcome. The dye is the traditional companion at birth, and if the woman chooses her to come into the labour ward with her, that's the woman's right. It's a human right and it's her choice. So we should never neglect the women who for centuries all around the world have been with women at the time of birth. But we also can't expect them to have the very advanced bachelor degree, master's degree, midwifery skills. But that's part of the team that we were talking about, because the woman's emotional side, the oxytocin, cortisol release is very important. So the dye or whoever you have is still extremely important in childbirth.
Not only is it what they do that we might want to learn about, it's what they don't do. So, for example, village midwives in ages past didn't cut a cord.
Because, and it's being found here in, also in England and places like that, what they call delayed cord cutting.
They were right in the first place. We'll come all the way back around.
Dyes would always wait until the placenta was delivered.
There are many uncertified midwives practicing in rural areas, and I think that they would also like recognition and support and training. They do recognize that there are many things that they don't know.
We currently have an atmosphere right now where they're not being engaged with. It's as if they don't exist, we don't want them to exist, but they are still taking care of women. And we need to engage with them so that they are encouraged to increase their education, that they are brought into a framework of safety and evidence-based care, and that we have mutual respect for them rather than ignoring them.
There should be a mechanism, a facility to enable those people who were dyes to scale up, to bridge, to become recognized as midwives, because they have a whole lot of expertise that they've learned along the way.
The dyers are very important to support the mother, so they can be with the mother, and there's known evidence that when mother is in labor, she prefers a female companion, and that's very useful because in the UK we have doulas. So the dyers could work as a doulas, but then you have a trained midwife that would actually oversee the case of the mother.
They're talking about one person who starts to see them through their antenatal care, who talks to them about their nutritional needs, their family needs, their financial support, their family support, prepares them for birth, gives them the advice they need in order to prepare them for the pending pregnancy and birth, anticipates their health concerns.
We earlier used to follow midwifery model of care, where the mother and the mother and the midwife used to be together. Now they are medically more oriented.
We've lost the skills of supporting normal birth. We've lost midwifery around the world, and where there are midwives, they've actually lost the skills of supporting normal birth.
The world doesn't have enough midwives. The world doesn't have enough other healthcare workers that understand midwifery and can work with midwives, can support midwives. I think we need to have ample numbers of midwives, but we also have to have them. We also have to have the jobs for those midwives.
Trying to work in midwifery becomes difficult because there are no career options directly in midwifery.
I do believe very strongly we have a huge problem, 22 to 25 million births a year, which cannot be done by doctors alone.
And the only way, again, as I say, to avoid it is if you have a companion through labor. So that's half the battle won, because if the mother is at ease, then the good hormones pump out. So these endorphins give rise to all the other good hormones as oxytocin and progesterones, etc., which are required. If the mother is stressed, if she's put in a stressful environment, her body shuts down. Your adrenaline and noradrenaline start pumping, and body completely shuts down, and you tend to edge towards a C-section.
Still people go to the obstetricians for their deliveries. They don't go to the midwives. Or even if they want to, their families don't allow them to do it.
Because what has happened over a period of time is due to the advancement of science and technology, the role of midwives has gone down, where every mother looked up to the midwife for her antenatal checkups and delivery and the postnatal care. Today they all are going to the doctors.
If you go into a medical training, a nursing training or a medical training, you can still do some of midwifery care. But people are patients, they're sick. I was a nurse. They're sick, they lie on a bed. They need to be cared for, they really do. When you are a midwife and you go into a midwifery course, you're dealing with the healthiest women on the planet. They are at their reproductive brilliance. And they're not sick. It's their birth. They don't need to lie on a bed. They need to do whatever they need to do. Stand, walk, squat, be on the bed. But they're not sick. So it's a very different philosophy of care, midwifery. And as midwives, we don't deliver women. We support women to deliver their own babies and to strengthen their own capabilities. So having been both a nurse and a midwife, they're both brilliant, excellent things to do, but they have a different approach. And I think a lot of the medicalization of childbirth that we're seeing is when people go into a medicalized training for good reason, but then turn something as natural as childbirth, where women are not ill, into something that becomes medicalized.
Maternity care provided by people who are not doctors is just as effective as care provided by doctors. And indeed, even in countries where midwifery is not a substantial profession, most of the delivery is carried out by that kind of person, with the doctor stepping in at the end. And after all, the doctor is medicalizing a normal process.
Giving birth is what we do since the beginning of time. We don't have to learn that. We know that it's all very deep inside, and we should use all the medical knowledge and equipment and facilities we have for the mother's good, and not to destroy a normal birth and make it a medical process.
The system has become so medicalized that people have to stand up against it and say enough to the medicine and the interference and to the medicalization of birth.
If you put skilled surgeons in charge of normal, they're going to do surgery.
I think this works really negatively, because then instead of enjoying the process of childbirth, instead of exercising her choice of maybe not opting for a surgical method, that is all denied, and she's agreeing to such procedures because she fears for the life of a child. She fears for the blame that would be heaped on her if something happens to the child later on, and she said, look, this happened because you did not agree to go for a procedure.
So if we're going to say that I want to put in an IV line just in case, then every time I go out to a party,
and I should put an IV line, because what if I have an accident on the way back home? I should have a lifeline. So by just giving up routine things, I'd like to think that the nurses that we work with, the doctors that we work with, have amazing skill to put a cannula in 30 seconds. So whatever the emergency is, they're not going to rip her open without any other, anesthesia or sterile environment. And in that time period, they can put an IV line by just not interfering or piercing her skin with a needle. We've already made the change. So we have access to all the technology, but we don't have to have everybody. We all don't have to wear helmets in our home just in case the sky falls down.
I would also say that when it comes to technology, it's not that I have anything against technology itself, because technology can mean a resource. We know there is a huge section in India who's not getting access to care. For them, technology can mean a world to them. However, how is it being used? It is being used under the influence of certain predetermined cultural notions, and that creates an issue, and that results in women being unheard across all sections. Now, this factor does not change whether it is too much too soon or too little too late or nothing at all. The final underlying factor becomes that the woman is not being heard.
A woman at that moment is the most vulnerable person. She is a strong person because she's bringing forth life, but she's also vulnerable because she's depending on others. She's in great pain, and at that time is the only time that someone else can treat her and get away with it. So I think a lot of sensitizing of the nurses and doctors has to happen. I think the training programs have to shift focus from only the technical aspects to include more sensitization and feeling.
Well, there's certainly not enough education, that we know. They might have one session, maybe. But many doctors are very committed to the well-being of their patients. I think they don't always see it in the terms that human rights gives us and the language and categories human rights gives us. And I think there are many doctors for whom, when they do kind of understand those issues, then it, in a way, gives them a language for something they already feel in their gut. So certainly for the ones who feel it in their gut, it facilitates what they can do.
I think it's complicated. I think, many obstetricians don't have exposure to what it's like to work as a team with a midwife. And I think that that's probably where the bias comes from. And I think that that's more of the issue in the settings I've seen than the concerns about the finances or concerns about ego.
I think I see problems on both sides. There's a lot of environments where midwives are being medicalized and they're not really practicing midwifery anymore, and there's places where we're not opening the door to obstetricians that really would like to practice midwifery. So I'm really advocating for an interprofessional approach that starts with the education of doctors and obstetricians and midwives.
But when we do see a midwife delivery that started at home or a midwife labor, we have no training in what that handoff should look like. So there needs to be training on both sides.
I think some training for the medical, like in British Columbia, Canada, people do go in and train the people that are becoming doctors or nurses. They integrate their professional training, so they might have lectures in there to explain what is a doula, what is a midwife, and how can we... compassion and kindness is not very hard. It doesn't cost anything. But there has to be a way to implement it in the hospitals.
So we don't just train obstetricians and train a midwife separately and a nurse separately. When they train as a team and function as a team and appreciate each other's contributions as a team, really right down, we've even done trainings with everyone in the facility, down to the guards, the cleaners, all together. When they work as a team and train as a team, then I think that's one piece of the answer. I'm sure it's more complex than that, but that, I believe, is one piece of it.
See, traditionally, midwives have been people who have lots of experience in how to deliver a woman. They have lots of experience. That experience stands them in good stead, particularly in dangerous situations or complicated situations. On the other hand, they are not trained. Unfortunately or fortunately, today's world is full of scientific and technological innovations which makes life simple for everybody. I think the midwife of today has to be trained a lot, has also to be given the right sort of inputs, both scientific as well as in terms of infrastructure, so that she or he can deliver to the community at large.
They have to be legally accepted and integrated, okay? Because the qualifications, fortunately, unfortunately, are not recognized by the Indian government. I think we should have more programs for nursing students and nurses to study midwifery and be qualified midwives, because what they don't understand is, what the government doesn't understand is, if they are there, they can help us.
We need government to say women are important, the research is clear, midwives are the way to go.
Midwifery practice law should come so that they can independently practice, because they have these skills. Most of them, they have the skill. Even if they don't have, we can teach them. And we can make a new curriculum, teach them. But then unless there is a law, they will not feel confident to take full care of the mother, because legally they are not authorized. So that authorization should come.
There should also be some licensure surrounding it, so people know that this is an independent profession which can take care of women and in their childbearing years. There can also be a model where there is a supportive midwifery role. Nothing is wrong with that. I just feel that right now, where we are in a society where they don't really know who the midwife is except for the dais, I think we need to come together to create a professional cadre of people with education and with government licensure in order to make sure that the profession comes up as a whole, and then not leaving anybody behind.
So it is better if you have a midwifery cadre where only the interested ones will take up that profession.
The evidence is very clear. You just need to look at the Lancet series, the State of the World's Midwifery Report, that you have to have the education to equip midwives to be able to function to their scope of practice.
First of all, the education has to be adequate. And I think at the moment there's probably not enough time spent on midwifery. In many countries of the world, direct entry midwifery has been really successful. In the United Kingdom, we have mainly direct entry midwifery at the degree level. So the status of the midwives is increased. But what we found is that the students who come into direct entry midwifery, they don't have to be nurses first, are often women who've had babies, and they've either had a good experience or a bad experience. They come into midwifery wanting to improve care.
In Australia, we have a Bachelor of Midwifery, which is 3 years you'd study to become a midwife, no nursing first. And those women are often doulas. They often come from being doulas and birth workers, and they come in and they become professional midwives. So we need to think about ways of not dismissing them and saying they're uneducated and they're dangerous. We need to incorporate them and upgrade their skills so that that wonderful traditional knowledge is married with good scientific sound practices.
That's what this is about. It's about not throwing out the value of the wisdom of our elders while we embrace the benefits of modern technology. It's about marrying the two, and I think we've gotten a little bit out of balance here, not just here, really globally.
Midwifery is effective when there are skilled, educated, compassionate midwives, and it takes a lot of intellectual skill, knowledge, but empathy and compassion and understanding of social and psychological situations. Midwifery is actually quite complicated. It needs a high level of development.
If you're trained only as a midwife, you cannot be posted onto the orthopedic ward. You are 100% mother and baby care. Whereas if you are both, all at the same time, you're doing vaccination campaigns, you'll move to the mental health unit, you lose your skills. Midwifery is so skilled that if you don't practice all the time, you can very quickly lose the skills.
Bring back midwives. They are there. When I say bring back, I'm saying bring them back formally, where we recognize them, we give them further training, so that younger women also go into midwifery in our communities.
We need to have midwives that know their communities and value their communities. They're committed to them and they want to stay there for a long time.
So we need a blend. That really modern, it's not as simple as give it back to the indigenous healers and everything will be okay. But we need the technology to keep people alive. And so we need somebody that has the education to be able to critically think around that. And there's clear guidelines. There's really clear guidelines. But it doesn't have to be nursing. I mean, you don't need to know how to take care of a diabetic 45-year-old man in order to be a good midwife. But you do need to understand both the medical aspects and the psychosocial aspects and the health promoting aspects.
You cannot do a water birth without a midwife or a doula. It is impossible because I can't sit with the mother for like 8 hours and 20 hours, which they do.
The mentality of the midwife and the surgeon are fundamentally different. Surgeons are impatient people. That's why they become surgeons. Midwives turn patients into an art form.
We all need to have conversations together along with the doctors.
We have to get in a companionship integrated program where you have a doula or a midwife, which can work in tandem with an obstetrician. That's what I do. I work closely with a midwife or a doula. We all work as a team. And I step in only if there is a complication. Otherwise, I let them do their thing.
When it comes to delivery, maternal care, neonatal care, that these midwives could be trained to do that. And again, they should be also, it's not just one aspect of it. Midwives can be trained, but they should also be taught when to refer and how quickly to refer.
And the way that the integration happens matters a lot. And I think often that's a detail that's lost. What does the handoff look like? When things go bad, what is the reassurance that the patient will be transferred appropriately? And that even on the obstetrician side, that they'll deal with that transfer appropriately.
I think that midwifery, standing outside the practice of medicine around a normal process, should merit a profession on its own. And I think the best examples are in other places where it's been successful. So we do have midwifery cadres in the United Kingdom, in the Netherlands, in Sri Lanka.
Sri Lanka has able to reduce the maternal mortality 60 years back just because of the midwives.
Sri Lanka, it was about training and educating and regulating midwives and putting them in the communities near to where women live.
And it has virtually halved their maternal mortality rate every 10 years until now. And what they have now in terms of their maternal mortality rates, considering that Sri Lanka is a low-income country, is amazing, admirable.
So it's very clear that we can, through a model of midwifery care, and if I can take you back a couple of centuries, it's exactly what the Swedish did. And they had one intervention, and it was midwifery, and we saw a rapid decline in maternal mortality without all these other things going on. It is the most important thing to save the lives of mothers and babies.
I think if we look at countries where you have really strong, good services for women, there are a number of features. Number one is that the midwives are educated and regulated. Their scope of practice is well defined, and they have the competencies, the knowledge, the skills, and the attitudes. I think the second thing is that there is collaborative work, so that we work as equals within a team. We know what our role is, we know what the role of the obstetrician is, we know what the role of the neonatologist is, and the others who work with it.
Historically, from the country I come from in the UK, just over 100 years ago, after lots of different people providing poor quality midwifery care, we had a high maternal mortality and newborn rate. With the help of the establishment of the Royal College of Midwives through Parliament, the Parliamentary Act set the regulatory standard. That meant that midwives were protected as well as the women. It's very important that you have a standard against women are regulated in practice. And that sets out what midwives can do but what they can't do.
There needs to be standards and credentials for those midwives. There are a lot of different standards that are out there, particularly country to country, and there needs to be assurance to the public that the training is adequate.
Regulation protects the mother, the baby, and the family. It also protects the practitioner, whether she's the midwife or the doctor. And without that, we cannot have standards of care. And it's not possible to measure or monitor or improve quality and make things happen. So it's the first step. You educate, but you regulate that education. You practice, but you regulate that practice. It's extremely important. And it gives status to a profession that has to stand up to that status. and it sets a high standard. So very important.
My vision is a collaborative model of care where the midwives provide the primary care role for the pregnant woman, and with the medical aspect of it, whether it is the OBGYNs or whether it's a physician or whether it's a pediatric unit or wherever it is coming into play when the need really arises, and having a supportive role, but also having a nice back and forth where the obstetrician and midwives talk to each other.
And I think that's whether we're in rural areas or urban Indias, the collaboration is essential, because really we need the high level, highly skilled practitioners like the obstetricians to be free for the high risk cases, and really have the midwives and the healthcare workers very well trained so that they can take care of the masses. Because we're seeing that the masses flooding the institutions and the OBs is just not working out.
We can offer a same natural birthing environment, but with an attachment of a surgery or a neonatal unit for immediate care should that one mother require it.
A woman, a doctor, a midwife could all be part of the same community of health service. Then these women, then I would say that they truly had the choice.
Coming from WHO, I can say the evidence is very clear, particularly in the recent Lancet series on midwifery. And we know that where teams work together, the outcomes are much better for women, for the newborns, and for their families. And we have a very well-proven model globally of midwifery-led care, and that means that all women will see a midwife antenatally, during her delivery, postnatally, and the family is part of that process. If there is a problem, she gets referred to the obstetrician. The obstetrician has a very specific and important role, but for them to spend their time doing extremely important things like massage or taking the woman to the toilet or talking with the family is not a good use of their extraordinary skills. So to have a team where you have the DI or the companion with the mother, with the midwife, doing all the normal beautiful care around physiological birth, but as soon as there's a problem, they're referred to the obstetrician. So it's very cost effective, it's very emotionally supportive, and we know that the research by Jane Sandel and many others proves that the outcomes for women, the newborn and the family are actually better than when we don't have that teamwork and that midwife-led care.
And instead of having this territory, or we're the only ones who are the experts, or we can only do this, if we work together, everybody benefits. If we value each other's role in the entire system, this has been shown time and again. This is very evidence-based, that integrated systems where you have distributed care, where maybe you have rural health centers, they're staffed by midwives who themselves support the traditional midwives and the community workers and the community health workers. It's happened all over low resource, middle resource countries. And in fact, that's what happened in high resource countries to build them to where they are now.
Where you have a midwifery model of care, it's never too much too soon, because you're with the woman from the moment she knows she's done her pregnancy test. That's where the midwifery care starts. So all along you have a continuity of care, so that by the time she goes through labour and birth, you're with her all the way. So it's not too little too late. And we know that where you have midwifery-led care, the caesarean section rates are much less. And they're there when they're needed, but they're not there all of a sudden too late. And midwives can't deal with, they're not trained to do caesarean sections, but my goodness, they're trained well to find out that this woman is going into a place where we need some extra help. Now we refer her. So it's not all of a sudden too little too late. It's planned, there's a referral going on, there's discussions, there's teamwork.
Actually, in Indian context, when mothers are coming to the hospital or in a health center or anywhere else, we are not giving due respect to the mothers. That is not actual humanitarianized this one. No, we want to shift towards the midwifery-led care model, so that we treat the mother as human beings. Also, we save the rights of the mother also. That is missing in our care model.
We would like that all mothers, like in other countries, especially in Sweden and Finland, where I visited, when the woman becomes pregnant, she reports to a midwife for which she has a license, whereas in India that license is not available.
If it comes, things will start moving towards making independent midwifery practice.
Because today midwives are not allowed to practice in many places, even though they have the skill, they have had the training, but they are not allowed to practice, so they lose their skills. So every midwife should be allowed to practice. Every maternity center should be led by the midwife. She should be the one to decide whether she will go for a normal delivery or if there is any complication, refer to the obstetricians.
The Western model of autonomous professional midwife, where a midwife is in charge of the entire process, she's making decisions, her education and her clinical expertise is superb. You know, it's rigorous. There is definitely a place for that in India, without a doubt. And these midwives can work within public, private, hospital, birth centre, or independently. And we just need so many of them.
That we really bring back midwives. They are there. When I say bring back, I'm saying bring them back formally, where we recognize them, we give them further training.
As a doctor, as a nurse, you're being exposed to so much medicalization that we might dilute our care. So I think in education, first thing, having a midwifery cadre who solely works on that so that they do not get diluted with all the other things happening in the world, and starting to include in the curriculum respectful care, include in the curriculum the art of having normal physiological birth.
Along with that, the supporting structures like referral protocols, ambulances for transport, clean hospitals. But all that comes with training and bringing in that whole concept of care, respect, kindness.
Women get midwifery-led care. You know, all the research shows that midwifery-led care is better for women, is better for babies, is cheaper. You know, so my vision is that every woman have a midwife care for them.
The Indian voices need to be the ones to say what do we want and how we're going to do it, and it has to move forward, because otherwise this conference, so it's been brilliant, but the next step is, the difficult step is how to implement the change and how to make it happen. Because there's so many people wanting midwives, there's people calling and trying to get them from abroad because they're not finding what they want here.
Midwives in India want women-centered and team-based approach.
Midwives want to shift in practice, policy and protocols.
As a nurse midwife, I want legal protection, because whenever something goes wrong, they blame only the midwives as a personnel, and it is like very difficult to work in that situation. So if protection is there, so we can work freely and without fear.
Improvement हो सकता है, वो बस यही है कि इसका लेवल बढ़ाने के लिए इसकी अलग से ट्रेनिंग होनी चाहिए, जो जीएनएम के डिप्लोमा के साथ इंक्लूड होनी चाहिए. इसी बिहाफ पे हम लोग अपना स्टैंडर्ड बढ़ा सकते हैं, ऑथराइज हो सकते हैं, और ज़रूरत पड़ने पर किसी भी पेशेंट को मेडिकेशन दे सकते हैं और रेफर कर सकते हैं इमरजेंसी.
एज ए मिडवाइफ मैं ये चाहती हूँ कि जो मेरी डिग्निटी और रेस्पेक्ट है, जो मुझे मिलना चाहिए वो मुझे मिले, जो अभी भी नहीं मिल पा रहा है.
The autonomy should be provided to the midwives, especially in India, to work in India as a midwife, not just as an assistant to any of the doctor.
Every single woman on the planet should have a midwife.
Introduce autonomous midwifery into the country wherever there are facilities providing midwifery maternity health care.
I know what I'm seeing in Kerala is not what is happening in Chhattisgarh and what is happening in Jharkhand. It is a totally different issue, and I as a midwife would want to be sensitive to what women all over the country are experiencing. This is important for me to learn. Also to talk to other people in the field, to talk to policymakers, to talk to lawyers, to talk to other people, doctors, to talk to midwives, to understand what they are going through in their geographic region. And I think this is important for me as a citizen of this country, to know what my women are going through.
I say that the country should be flooded with trained midwives.
Their voices mirrored the voices of the midwives of the globe who, in the Midwives Voices Midwives Reality Report. They want to be recognized as midwives. They want the regulation to do that. They want to be educated so that they do have the skills and the competencies to provide the care. Many describe being left in situations where they don't have that.
And what midwives want is what's best for women. And, you know, this has to be discussed with midwives in the Ministry of Health. They need to be at that policy table helping the Ministry of Health to guide them to work together to say, this is the policy that would work for us, and if it works for us, it works for women and newborns. So what they want is respectful care, rights-based for all women, newborns and their families. And to be able to provide that, they need the professional support, the education, regulation, licensing, and they need that support. They also need economic support. They need to be able to be paid a reasonable amount to make sure that they can continue to come to work. They need career progression that matches their economic and their professional experience. And they need all of this to be acceptable socially and culturally. Often midwifery is seen as women's work, don't bother paying them. We need to promote how midwifery is developed in other countries, and all of that sits within a gender equity. So these are big thinking issues, but if you ask midwives, they know what they want, and they need to let the government and other stakeholders work together to help support them and to be leaders within that.
So I would suggest that India rethinks, takes the best from around the world, develops direct entry education at the degree level, but also helps those nurses and midwives already in practice. Brazil has set up internships, conversion programs, so you can do another program to learn midwifery skills.
So my vision is what the vision of any midwife, who really is a true midwife, is that all women have a respectful experience that's positive, based on their right to emotional, psychological, social support with the highest quality clinical care as it's needed, and supported throughout by a midwife, their family, their DI, their companion of choice, not just at the time of birth, but pre-pregnancy, pregnancy, during childbirth, postnatal, and all the way through.
Each of us needs to be awakened. We need to find that moment of epiphany. And I'm confident with all of us talking about it, using social media with a little more sensitivity, I am confident there will be a change.
My vision for midwifery in India is that there is a cadre of midwives developed, educated, trained, supported and regulated, because we know that is what makes the difference. Any country who wants to rapidly reduce its maternal mortality rate, this is a key area of investment.